Okay, let's unpack this. You sent us your MSRA revision notes on typhoid fever.
Yeah.
So we're going to do a deep dive, really pull out the absolutely essential stuff you need for the exam.
Exactly. Not just reading, but highlighting the high yield points. We're talking typhoid, also known as enteric fever.
Caused by that bacterium,
Yeah.
Salmonella enterica serotype Typhi.
That's the one. And it's mainly spread through contaminated food and water. It's a systemic infection, causes that prolonged fever.
So our mission here is really to make the key facts stick for your revision.
Yeah.
Make it less daunting.
Precisely. We'll trace it all, what it is, how you get it, what it does inside the body, the symptoms week by week.
How to spot it, how to treat it, and what can go wrong. Basically, your fast track to the core knowledge.
Right. So, starting point, the definition. Typhoid fever, or enteric fever, caused by Salmonella enterica serotype Typhi, a bacterium.
And the key transmission route.
Contaminated food and water, that's number one.
Simple enough, but critical.
Yeah. The bacteria live in the intestines of infected people, shed in their feces. So it really comes down to issues like poor sanitation, poor hygiene.
Consuming contaminated stuff. It's fundamentally about hygiene.
Absolutely. And a key point for the UK, it's a notifiable disease. Public health needs to know.
Makes total sense. Okay, so that's the etiology contamination linked to human waste. But who's actually more likely to get sick? The risk factors.
Good question. Your notes break them down nicely into three groups: environmental, occupational, and host factors.
EOH. Environmental, occupational, host. Could be a handy way to remember it. Environmental must be the obvious stuff.
Yeah, poor sanitation, lack of clean water, eating dodgy food or water, being in close contact with someone who's infected. Basically the environment where the bug can spread.
Okay. And occupational.
That's about your job. So healthcare workers, maybe food handlers, people working in labs with the bacteria itself, higher exposure risk.
Right. Then host factors, but that's about the individual person.
Exactly. Things that make you more vulnerable if you do get exposed, like having low stomach acid, achlorhydria, or being immunosuppressed. Co-infections can play a role too, like schistosomiasis or malaria, extremes of age, very young, very old, and certain blood conditions, hemoglobinopathies.
So EOH, where it spreads, who gets exposed at work, and who's personally more susceptible.
Got it.
So what happens after exposure? The pathophysiology.
Right, the bug's journey inside the body. This is fascinating.
The bacterial timeline, let's call it, starts with ingestion, obviously. You eat or drink it.
You swallow the bug, and if it survives your stomach acid, remember, low acid is a risk factor.
Oh, connects back.
Exactly. Then it invades the lining of the intestine. And here's a key step. It gets picked up by immune cells called macrophages.
But it doesn't get killed.
Nope, it survives inside them. It basically hijacks them.
Wow. So our own defense cells give it a ride.
Kind of, yeah. They travel in these macrophages, first to the lymph nodes, then they break out into the bloodstream. That's the systemic spread phase bacteremia.
And once it's in the blood, it goes places.
Yeah.
Organ involvement.
Yes, it likes to set up shop in the liver, spleen, bone marrow particularly. The body fights back, of course, the immune response kicks in, but that causes inflammation and damage, leading to the symptoms.
Okay. And the notes specifically highlighted the gallbladder. Why is that important?
Crucial point. Bacteria can get into the gallbladder from the liver via bile. They can live there, multiply, often without causing gallbladder symptoms themselves.
And that's how it gets out again.
Precisely. It's shed from the gallbladder into the bile, back into the gut, and then out in the feces. This explains the chronic carrier state people shedding the bug long after they feel better.
That makes so much sense.
Yeah.
Explains why it's systemic, not just gut and the carrier thing. Okay. Crucial for exams, differential diagnosis. Typhoid's a great mimic, right?
Oh, absolutely. It can look like so many other things, especially early on. You've got to think broadly.
Like what? Other fevers?
Yeah. Paratyphoid fever caused by related salmonella, viral stuff like glandular fever, maybe malaria, especially in travelers, even autoimmune things sometimes.
But the classic MSRA scenario is probably the returning traveler, isn't it? Febrile illness, maybe tummy pain, headache, rash. That list is long.
It is long, and you need the big hitters in mind. Malaria is always top of the list. But also think amoebiasis, flu, TB, typhus.
Okay.
Viral hemorrhagic fevers like Ebola, dengue, other non-typhoid salmonella, Campylobacter, cholera, scrub typhus, even things like an abdominal abscess, yellow fever, African trypanosomiasis.
Wow. Okay, that returning traveler differential needs serious attention. Maybe thinking about where they went, what they might have been exposed to, helps narrow it down.
Definitely a good strategy. Group them geographically or by transmission route in your mind. So where and when does this actually happen? Epidemiology.
Well, in the UK, thankfully, it's rare. Mostly travelers or people who've had close contact with them. Notes say it's been decreasing too.
Yeah, about 7% year-on-year since 2011 for both S. typhi and paratyphi. In 2017, S. typhi was about 61% of cases, paratyphi 39%, though S. paratyphi B, linked to Middle East travel, was holding steady.
But globally, totally different story.
Completely. Still endemic in many developing countries, especially parts of Africa and Asia.
Yeah.
Huge burden. Latin America's seen some reduction, which is good.
The WHO estimate is massive, 11 to 20 million cases a year.
Staggering. And that comes with significant morbidity and mortality where sanitation is poor. Even seasons can affect it in the tropics. Hot, dry seasons, rainy seasons.
And the mortality difference is stark, isn't it? Less than 1% with treatment, but potentially 10–30% without in 4 conditions.
Huge difference. It often clusters in families linked to poverty, poor housing, and there's that note about HIV/AIDS in Africa increasing similar illnesses caused by non-typhoidal salmonella.
Right, okay, so we know where and when. Let's get clinical. What does the patient actually look like? Clinical features.
It often creeps up on you. The fever usually increases gradually over the first week or so.
Not sudden high fever.
Not typically. Alongside the fever, common things are headache, often quite persistent, feeling generally unwell, malaise, losing your appetite, abdominal pain, weakness. Diarrhea can happen, but sometimes constipation is the initial thing.
Okay, but what about the classic exam clues, the ones you have to know?
2 big ones. Rose spots, faint pinkish spots, usually on the abdomen or chest. They can come and go.
Right, rose spots.
Yeah.
And the other?
Relative bradycardia. The heart rate is slower than you'd expect for that level of fever. It's a really important sign.
Definitely remember relative bradycardia. And in severe cases, things can get nasty.
Very nasty. Intestinal perforation, major bleeding, liver or kidney failure, sepsis.
Okay. Now that timeline, the untreated course, week by week, this seems super high yield.
Absolutely critical. Incubation is usually 10–20 days for S. typhi, maybe some early transient diarrhea in 10–20% of people, but the classic untreated stages.
Week 1.
Week 1. Think bad flu initially. Fever climbing, often hitting around 40 degrees C, dry cough, malaise, that headache, but look for the relative bradycardia, maybe nosebleeds, epistaxis. Blood cultures are most likely positive now. Leukopenia low white cells might be seen. This is the bug getting into the blood after invading the gut.
Got it. Flu-like, plus bradycardia, maybe nosebleed, week 2.
Week 2. Fever stays high consistently. The patient feels much worse, maybe confused. This is when the classic rose spots usually pop up. Tummy problems worsen. You might feel an enlarged liver or spleen hepatosplenomegaly. The Whittle test might start becoming positive now, but remember its limits for acute diagnosis. The bug has spread systemically.
Okay, classic signs emerge in week 2. Getting worse. Week 3.
Week 3. This is often the worst phase if untreated. Serious illness. Significant weight loss, profound weakness. The abdomen can get distended. Diarrhea is more likely now, sometimes the classic pea soup description, though not explicitly in these notes. And crucially, this is the highest risk period for major complications, perforation, hemorrhage, peak inflammation time.
Sounds grim, if they make it through that. Week 4.
Week 4. You start to see improvement. Fever begins to settle. Mental state clears up a bit. Abdominal issues lessen. But recovery is really slow, really dragged out. And there's a definite risk of relapse even after improvement starts.
That weekly breakdown is pure gold for revision. Flu-like, classic signs, danger zone, slow recovery. And let's not forget the carrier state, linking back to the gallbladder. 2–3% of untreated people.
Yep, shedding the bug without symptoms. Huge public health issue. So how do we actually confirm it is typhoid? Investigations.
Gold standard, according to the notes. Blood cultures. Isolate the bug. Positive in about 61% of cases, it says.
That's the key one. Serology, like the Whittle test, exists, mainly used in resource-poor settings, but it detects antibodies that take time to develop, so less helpful right at the start. Newer antibody tests, immunoblotting ELISA, are better, but maybe not always available. Molecular tests, like PCR, are faster for detection. And don't forget stool cultures, vital for picking up carriers and also positive in acute illness. You can culture feces, urine, or blood.
Okay, so you've confirmed it. Management time. The absolute core. Antibiotics. Plus supportive care.
Absolutely. Antibiotics are the treatment. Fluoroquinolones, third-gen cephalosporins are mentioned. The crucial thing is choosing based on local resistance patterns and sensitivity testing.
Right, resistance is key.
And supportive care is just as vital. Fluids, hydration, managing fever, nutrition, rest, electrolytes. keeping the patient stable.
The UK uses national guidelines, which help standardize things, and vaccination for travelers prevention angle.
Yeah. The general principles are diagnose quickly, get the right antibiotic in, support the patient well, and strict hygiene hand washing, waste disposal, limit close contact, follow up carefully.
Okay, the specific antibiotic regimens. These look complex, but are probably very high yield for MSRA. What are the goals?
Ideally, a short course of treatment, fever resolves quickly, you clear the bacteria from the body, sterilize cultures, and prevent relapse.
And the options mentioned.
Extended spectrum cephalosporins, oral cefixime, IV ceftriaxone, oral azithromycin. But always tailor to the sensitivities. Duration is typically 7-14 days or maybe 5 days after the fever breaks.
Right, let's break down the specifics. Uncomplicated typhoid first. How do you choose?
Okay, for uncomplicated typhoid, if the patient likely got it in Asia, where resistance is common, the empirical choice before you have lab results is usually azithromycin. If tests show it's multi-resistant, resistant to older drugs, but sensitive to quinolone, you'd use a fluoroquinolone or cefixime. If it's quinolone resistant, increasingly common, then you're back to azithromycin or maybe ceftriaxone, usually for 10-14 days.
Okay, so origin and resistance pattern really drive that choice for uncomplicated cases. What about severe typhoid needing 4V treatment?
Severe typhoid, current rule. Again, if it's likely from Asia, empirical 5E choice is ceftriaxone. If labs show it's fully sensitive, you can use an IV fluoroquinolone, like afloxacin, for 10-14 days. If it's multi-resistant but still sensitive to quinolones, you can still use an IV fluoroquinolone like afloxacin for 10-14 days. But if it's quinolone resistant, you need IV ceftriaxone or cefotaxime for 10-14 days.
That's really complex but crucial. Uncomplicated versus severe first, then factor in the sensitivity or likely origin. Making a little flowchart for revision would be smart here.
Definitely. And treatment isn't just about the patient in front of you. Public health management is vital.
Yeah, collaboration, strict hygiene advice, excluding people like food handlers or healthcare workers from work until they're confirmed clear, notifying the health protection unit.
And advising contacts, co-travelers on hygiene, maybe screening them too. Community containment.
Okay, wrapping up. Prognosis and complications, generally good with treatment.
Generally good if caught early and treated appropriately, yes.
But if not, those complications sound serious. Intestinal perforation, bleeding, liver-kidney issues, sepsis.
They are serious, and that's why prompt treatment is key. Chronic carriage we mentioned, rare, 2-3% untreated, linked to the gallbladder. Things making severe disease more likely include older age, being sick for longer before treatment starts, and having a bug that's only partially susceptible to Cipro.
And mortality again.
Yeah.
1% with antibiotics, 10-30% without. Really highlights the impact of healthcare access. Relapse rate about 10% in untreated cases, too.
Exactly. Early diagnosis, appropriate antibiotics, that's how you prevent the worst outcomes. And prevention through sanitation, safe water, vaccines for travelers, hygiene, it all links together.
Phew. We covered a lot there. The bug's journey, the week-by-week symptoms, those critical antibiotic choices based on resistance, really drilling down.
Yeah, and if you take one thing away for revision, really focus on that clinical timeline, the weeks, and understanding the antibiotic resistance pathways for management. That's core MSRA stuff.
So here's a final thought for you to chew on. We talked about the pathophysiology, how the bug invades, travels, hits organs, gets out. How can linking that specific journey help you truly understand why you see, say, relative bradycardia in week 1, rose spots in week 2, and high risk of perforation in week 3? It's not just a list of symptoms.
Exactly. Connecting the why the path the bug takes to the what the symptoms it causes makes it stick so much better than just rote learning.
Definitely. Well, hopefully this deep dive has helped structure those revision notes for you. If you're looking for more MSRA resources, PassTheMSRA.com is a great place to go.
And don't forget freemsra.com, lots of excellent free materials there as well to help reinforce this kind of knowledge.
Check them out. That brings us to the end of our deep dive on typhoid fever.